So welcome back, and welcome back to our second conversation, which is around championing health information and valuing the professionals who work in this sector. And I was just doing a kind of quick tot-up. I think we've got around 200 people here today. And if I just even average that at 2.5 years experience of working in information, production, provision, support, I reckon we've probably got 500 years worth of experience in this audience, 5 centuries. And all of you will know just what an important role information plays in supporting and empowering patients to manage their health, to make informed decisions. But I think along the way, despite the kind of drive in policy terms, I think many of you in this field have felt that there's not necessarily always been a commensurate level of funding, support and resource for your area of work. And so one of the discussions and one of the questions today may be around how can we better promote and support this really important area of work. But it's a very changing landscape as well. So back in the days where we would print information, we now have digital online, as we were discussing this morning, and that's very much changing maybe the role and nature of the skills that are required to work in this area. So there's a lot of change that is out there. We also heard about peer support and the contribution that patients make to that conversation and to informing others. We had a very impressive lineup, and I'm pleased to say that we have a second very impressive lineup of speakers and panellists. And so I would like you to welcome to the stage Dr. Martin McShane, Medical Director for Long-Term Conditions NHS England, Kay Boycott, who's the Chief Executive of Asthma UK, Michelle Hawkins, Head of Futures at Virgin Care, and Dr. Andrew McCulloch, Chief Executive of the Pickett Institute Europe. Please come and join the stage. So I'm going to kick off and put it out to you. I have got questions that have already been filed, but the panel are prepared that they don't know necessarily what's coming at all, so they're prepared to freewheel and wing it, as somebody previously said. So have we got anybody in the audience who's got a question that you would like to put to the panel? Or do you want me to start off with one that's already been entered? Okay. Rachel Boyd, who's the Information Officer for Mind, could you show your hand and we'll get a microphone to you. And I think your question is around the information standard and its role.
Hello. My question is, how do the panel see the information standards role in championing patient information and communicating the value of quality information to the public?
So I think I'm going to ask Martin, if you wouldn't mind just maybe kicking us off.
This is a really interesting question, and as a GP, I was reliant on information, but I had no real understanding of its reliability. And from a professional point of view, I think there's listening in a conversation just before we started, someone said, if we could get the information standard to have the same recognition as, say, the fair trade icon, wouldn't that be fabulous? So that both professionals and the public would understand intuitively what that meant, have confidence, trust, and know that what they were getting was reliable. I think we've got a long way to go on that, and I think that's something I need to take back internally in NHS England and continue to support my colleagues who are doing fantastic work around this now in NHS England to see if we can advance this agenda.
Kay, as somebody who's working in a patient organisation, do you have the information standard? Do you think it's of value to your users?
Yeah, we see it as absolutely key to our information. I think there's two important bits of it. I think there's the sort of safety aspect, the reliability aspect, and that's very important. We've got the rather marvellous situation in a couple of weeks' time of having new NICE guidelines coming out, and making sure that things are in line with latest guidelines. That it is a great sort of great discipline. But I think the more important part, and the thing that I think will emerge over time, is the usability side. And I think one of the mantras that we talk about a lot is that there needs to be these three, safety, efficacy, and usability in all things is going to be increasingly important, because having great information that nobody uses, and the discipline of going through and talking to patients about the usability of that information is key. And I think the information standard does that discipline well. I think there is an evolution to happen in terms of the different channels that information goes out, and how will the standard evolve with that. And as information potentially gets more complex and more personalised, how is the information standard going to sort of cope and evolve with that as well? I'm sure we'll get onto the definition of what is information as part of that.
Andrew, did you have anything you wanted to contribute to that?
Yes, I think, well, you've just touched upon it. I think the area where information crosses with opinion is an extraordinarily difficult one. And I'm interested that the question came from mental health, which is an area I worked in for 20 years. I was just reviewing a book yesterday which was aimed at patients from a very distinguished organisation, not in England. And there were lots and lots of deeply controversial statements in it. For example, it said that 10 to 15% of the population suffer from a personality disorder. Now, if that is information, I'm a Dutchman. But so I probably have got some Dutch ancestors if I went on that show about your genetic origins or something. But that's what I mean, actually. So we've got to be very clear about, I'm not saying people shouldn't have opinions about epidemiology or opinions about contested areas. Of course they should, but it's a question of having the transparency. So yes, let's comply with standards, but let's make sure we're also transparent about what we're offering to patients. And if you like, being clear about what their perspective is going to be. So are they reading this leaflet as if this is hard science, as if it's on tablets of stone, or are they reading it in a different light? So being aware of the light in which it's being read.
And we talked earlier, I think, about the importance of knowing the credibility and the quality, and whether the information or content that you're accessing is evidence-based. But alongside the importance of being able to share other people's experiences and stories. And I wondered, Michelle, from Virgin Care's perspective, and whether you as an organisation have any conversations about information standard or the need for kind of that quality assurance.
Yeah, we absolutely do. So see things like the information standard, the quality marks, as thoroughly important. We've been focusing, since we came into the healthcare marketplace, on consistency and trying to look at across. We now have 230 plus services, and trying to bring consistency and quality across them. The information standard is something the marketing team are currently reviewing, and I think the benefits of having conferences like this is throwing up the importance of information, getting us to think long and hard about the value of information. But I think what we're also trying to embrace, and it goes on to the question we've just asked there about consumer-led information. So my role is looking at the future and the way the market is going, and I see this being much more patient-led and making sure that there is a combination of high-quality health information, but also some of the more outcomes-based care, how do I live with my condition, being generated by users, by patients, and actually letting the crowd look at the quality of those and having systems in place to help that get moderated. So I think it's quite an exciting time. I think the information standard potentially has a new role to play in that domain of consumer-led information. But I think we have to embrace it, because it is happening and it will happen.
Are there any people in the audience who want to comment about the information standard and how it's being used? Lady there. Sorry, where's the microphone? third row back.
Thank you. I'm Heather Wanstall from Prostate Cancer UK. Can you hear me? My question is how you get the customers or the user base to be representative. We have the information standard and we have our review groups, but they're very white middle class. And these are always seem to be the people who come forward for this kind of role. So have the panel got any thoughts or ideas of how we make things more representative?
Who'd like to tackle that first, Michelle?
And I just spoke. So going through voluntary sector partners, actually, so what we kind of focus on quite a lot is who is the right messenger. And we recognise the limitations sometimes we have as healthcare professionals in reaching the people we need to reach. So we work quite closely with voluntary sector organisations to then organise and do groups for us to feed back. So particularly some of our sexual health services, where I've been looking at quite a lot of service redesign at the moment, using great organisations that are able to assemble the hard-to-reach audiences, get their views and feedback in a setting which is familiar and comfortable to them, rather than trying to bring them into our kind of healthcare facilities, which are often quite intimidating and not natural environments from them. And also looking at curating things online, because online gives you much more opportunity sometimes to have an anonymous, open conversation. And there are partners who already have, I think from my side, it's important to go to where people already are rather than bring them to us. So we spend quite a lot of time mapping who are the people we want to engage to make it representative, where do they naturally hang out, and how do we then work with the place where they're hanging out to start having a conversation where they are.
Kay, from your perspective, obviously, of being in a charity that supports a huge number of people with asthma, how do you manage to get a broad section of people to comment?
Well, I think this is where we sort of differentiate between the core content. So asthma affects 5.4 million people, and they are everything from, small children up to pensioners. So there's no such thing as an average person with asthma, but you do have to decide with your core content it's very unfortunate. You do have to almost say there is a baseline in the middle. I think where we are, and that it is basically usable and understandable to a large number of people. I think the challenge we're facing at the moment is that a lot of information should be targeted at people who don't really care about their condition. If you're highly engaged, then actually you will have the agency to go and find that information, and you're not our target audience. And those are the people that will go and read us panels. So what we're doing is supplementing that with more work around the people that aren't engaged, which is, the people that don't exercise all the time. They're everybody. They're most of us, people who are not activated all the time. And using that insight to change some of the content. The difficulty within the rigidity of something like the information standard is how do you then prove that those insights are then sort of tracked back to an evidence base? And I think that's why we think of core content, and then how do you use that content to go out in different voices. The important thing for us is maintaining that the clinical side, the adherence with guidelines, things like that, is always kept absolutely there. But I think that's why I was sort of saying before, there needs to be a bit of flex and a bit of recognition that different channels are going to require things, and we're going to need a little bit more qualitative interpretation, because if we look at our audiences, there's probably about, I would imagine, we think there's about 8 different segments, and there's about 4 different needs. So that's, we can't do a really, really good panel for each of those. That's impossible to recruit to.
Thank you. Martin.
So this is absolutely fascinating, because in my journey through as a professional through healthcare, what I've realised was I started in one century, where my role and purpose was completely different to now. So in a sense, I was the Wikipedia in the 20th century. I had the information, the experiential knowledge, and people came to me for that. They don't need me for that anymore. So what is my role? Well, I think there's a role that we need to redefine for individuals who are seeking help, and a role we need to redefine for professionals. And one of the interesting things for me was chairing a conference on international care models and coming across Nuka in Alaska. And what struck me was they call the people who register with their healthcare system customer owners. They don't call them customers, they call them customer owners, So it immediately is a signal that you own this system, which gives you some responsibilities as well. But also, I was at a meeting yesterday. We're doing work with some of the big pharmacy companies on looking at the role of pharmacy in addressing long-term condition management. And when they set this study up, I asked them to use a technique which we've been piloting called patient activation measurement. And the really interesting thing is that their pharmacists are saying that because they're using this technique of measuring patient activation at the beginning of a consultation, it's then changing the way they behave with the person in front of them, because they understand them, where they are in terms of health literacy, and so they are personalising that interaction. And I think what we measure is incredibly important, and we do not measure enough about meaningful care for individuals. So I think patient activation measurement is one. I think the work that Al Mully and the Dartmouth unit have done on collaborate and integrate measurement is a step in the right direction. I would say as well that, picking up on the point on channels, we haven't yet truly understood how interactive information and support can become in a digital era. So I used an app recently. I tested it on myself. It was very brave of me. Called Sleepio, which is a 6-week course of cognitive behavioural therapy. But it doesn't just give me information, it requires me to interact with it. And then the algorithm tailors that information back to me in a way which is personalised. So I think we really are on a tipping point of a real change in how we can use information. But what we also need to realise is it's a bit of a wild west, and that brings us back, and we need to anchor in the information standard and use perhaps some of the rigour of the pharmacy industry in what we're doing with apps and interactive information and managed treatment, if you like, in the new world. So
that's a very nice segue onto a question I just hear we've had from Twitter. Claire, from somebody in the pharmaceutical world.
Yes, it was. What is the role of the pharmaceutical industry in being part of health information?
I don't know. Well, people from the pharma industry are here in the exhibition area.
I think one of the things that we're sort of getting into is that the information standard covers a proportion of information, but actually we're seeing the edges of where some of this is going to happen. And just to give an example, I was at a recent European conference which was talking about prescription algorithms, because asthma is an episodic condition. Today, lots of people who have certain triggers are finding that their asthma is worse. They might be absolutely fine in the winter, and other people with asthma will not be when colds and flus. So the way that treatment is taken is highly variable throughout the year. And what most people get is a prescription at one point in time. But what people with asthma actually want is a much more detailed explanation of when to take it, and really getting quite granular. And there was a study done in the Netherlands where they were giving people a personalised algorithm of when to take their oral steroids. And that's really important for people because they don't like taking oral steroids. And they did it for a 6-month research trial, and then they stopped. And that was highly distressing to that individual. And there's an interesting thing here, that was personalised. It was a physician to a patient. But we can see that we're not far off the shelf algorithms being made available. Is that information or isn't it? Is that something that we're going to put in to make that more personalised? And how is that piece going to start to be regulated under an information standard? Because that's the stuff that's currently on an asthma action plan. If your trigger is this and if this happens to you, take that. So in some ways it's just the next iteration in a slightly more personalised piece of information. But because it's technology, I think is that we're then getting into, is this a device? And these are the Wild West areas that I don't think we're having enough of a dialogue about.
Andrew.
I think this really is the cutting edge of where the healthcare industry as a whole is at the moment, because it raises the issue of how we've set the system up. So put it crudely, I realise this is very crude, we've set the system up in a certain way, so we do RCTs, we have an idea of what gold standard evidence is, and we try and drive practice in that direction. Well, that's all going to be blown out of the window now, because that's going to become history, because we're going to have the in vivo data coming in that's going to tell us what individual patients' experience of individual treatments is from a variety of different perspectives. And we're going to be able to analyse that. And my guess is that's going to show us something completely different. And it's going to show us something very nuanced, very granular, and somehow we're going to have to create information out of that so we can throw away all the leaflets that say the side effects are this, the dose is this, and so on and so on, if you like, because it's actually going to be a whole different world that we've got to grapple with, and we're going to have very, very complex algorithms to produce information that's going to be meaningful at that level. But that is the challenge that we're going to face with big data, and somehow we've got to get ready for that now, because it's probably going to happen very quickly. And to me, it's very welcome, because I think we've been going down what for a lot of individuals has been a bit of a blind alley, because they have been told that treatments are effective, but they're rightly so on the basis of the way we've set it up, because the evidence base says it is effective, but it's not effective for them in their circumstances, in their setting, with their team, and with their whatever they're doing in terms of their concordance. So I think where pharma comes in is they can be more intelligent about this, and they are being actually, and looking at patient journeys and so on.
So yes, that was my question. So do you foresee an even greater role for the pharmaceutical industry in supporting quality information?
Those parts of it that have the resources, the will and the vision to engage with that will do so, and others will not.
Martin?
I think there's an historical issue, and the elephant in the room is that we will need pharma to step up and be transparent, and in its use of the information, the data. I think it's absolutely critical that pharma are involved. I think that they have a great potential to do good, but they will have a conflict of interest, and so we have to create an environment of trust and respect, and mutual trust and respect, so that we have complete transparency about data, its publication and its results. I know that Fiona Godley at the BMJ has done a lot of work on this as well. I just want to make a point about data. I think our inability to link data currently in the NHS is sustaining harm and preventing us from delivering benefit. Now, this is a really, really difficult and tendentious area, but the NHS, if we are to create a sustainable NHS, which delivers value for the taxpayer pound, and I have had the privilege of working in a health system where I've never had to ask anyone, can you afford the treatment I think we've agreed you need, then we are going to need to embrace and make possible the ability to link data. Because at the moment, it is embarrassing the lack of knowledge we have and the harm that is happening and is hidden from view because we are not allowed to link data.
Michelle?
And I think from that very difficult situation has probably sprung the emergence of patients asking for and owning their own data, in collecting information, in having these kind of digital apps, so they're gathering in it. And you can see in the future that the hub will completely change to the patient's smartphone or Apple Watch, whatever they have, and we will then have to integrate back into that and have a conversation with the patient to release that information so that we can have a more holistic picture of their care. But back onto the original pharma question, I actually think it's really important that pharma can be a force for good as well, and the opportunity to collaborate. So none of us is going to be able to solve the challenges on our own, and I'm certainly very open to working with a combination of people to help solve and tackle problems, be they bringing academia on board to get the robustness and the validity and the evidence as a provider, having access to services and to patients and to professionals, bringing pharma into the picture who have potentially the resources and the needs to come on board in a conversation, anybody else to help tackle the problems rather than me trying to solve it alone.
So in fact, there's a real importance of patients being able to access the right information, be that content data, at the right time along their care pathway. And I think we've got a question related to that from Meg Muller, or if there's a typo, I hope it wasn't Meg. Thank you. Over here.
How do we begin to get, sorry about that. How do we begin to get high quality information embedded into the patient pathway? It's very often an afterthought. It's not prioritised but it is an important part of patient experience.
Marcy, would you like to kick us off?
Yeah, we must get it embedded into the pathway. Any good industry builds doing the right thing into normal workflow. And as a GP seeing patients, in the early days of computerization, I was terribly excited that I could actually, in a consultation, seeing a patient, trigger printing off material for them to take away and use. I think, though, this actually begs the question, and I was with Martin Wildman in Sheffield, who runs an almost perfect example for me of 21st century long-term condition management, where they measure everything, including adherence, digitally. They give that information. They use that to drive their behaviours with individuals. They tailor their consultations around the needs of the person, not the person around the needs of the organisation. But the one thing he said to me was, in their journey, and it is a system which supports them to do that at the Sheffield Foundation Trust, he said that what they've learned, the key thing they've learned is, if you want to change patient behaviour, the first thing you have to do is change professional behaviour. And it really turned a light bulb on for me, because I thought, well, we can create patient pull, we can create patient push, whatever. I think until we actually get that new culture of, as a professional, I am a guest in someone's life. I am alongside them and a navigator, a coach, a mentor. The one thing I'm probably no longer is a director.
Kay, from your experience, you've got a wealth of information coming through on social media. What are some of the stories about the experiences of people with asthma?
Well, I think it's all about, rather than thinking where does information go in the pathway, that sort of feels like quite, you're just trying to shoehorn it in. And I think what our experience is that you've got to, I think people are going to have to be even more highly targeted about where the information and when the information is going to be delivered. So I'll just give a couple of quick examples. Today, it's hot, there's high pollen, and there's threat of a thunderstorm. Those are unfortunately very, very likely triggers for asthma attacks. So what we've been doing is using our patient information that is our standard information on our website, but translating that across social media and into the press as well. So it's literally just repurposing the content. But we also use the fact that we start to see the signs of that 3 days before, because asthma attacks start 3 days before. And I think using those to be more timely, if we did that in two weeks' time, no one's going to be interested. The message is the same: take your preventer inhaler, which people should be doing all the time anyway, but it's about reaching them at the right time. And I think patient activation and measures, and more of that data is going to be even more key for information professionals to decide where the information goes. So asthma has been proven to work with the patient activation measure, but there's a very interesting thing, which is if you are hospitalised with an asthma attack, you are likely, much more likely to be hospitalised again or die from an asthma attack. So of course the obvious thing is before you get discharged, let's give you lots of information, let's make sure that's the teachable moment, you've been scared, you'll do that. Whereas actually at that point what patient activation will say, you're probably less activated. And then if you think about it, if you're a mother who's just been in hospital or a parent who's been in hospital with a child for 24 hours and you haven't slept, that is not the time to be giving you information. Of course it's not. And yet we've fallen into those traps. And I think one of the techniques we do a lot of is it's a very simple 4x4 matrix, which is what are people currently doing, what do you want them to do, what do they think, feeling and believing, and what do you want them to think, feel and believe. And being really realistic about that. And if you've just spent all night with a child in hospital, what you're thinking is, I want to go home. You are not thinking, let me have a teachable moment at that point. So I think it's being much more sophisticated with the data to pick exactly, a bit like, you know, how do you buy in the old days, the TV spots, you were very targeted about where it was. I think we've got to be just because information can be distributed more through cheaper channels doesn't mean you should do it.
Michelle, is there anything that you're specifically doing within urgent care in your operations to look at how information is used along that journey for people?
Yeah, so I'm one half of a design function at Virgin Care. So you've got service design and me within Futures, and what I start at the start of that process looking at insight and how we look at the audience's need and build segmentation. So really at that point, I guess I'm starting to have a look at what are the information gaps and the information needs, and then my service design colleagues will design workshops with users, with staff members, to start looking at how do we put information into the pathway and embed it in. But there is, as we've just been discussing, a need to, while you have formalised structures, the training for staff to feel that they can also react in the moment appropriately, that just because you have a guideline and a pathway to follow, you need to have the common sense and the permission. And there's a lot of work that we have to do about people thinking they have permission to respond and to then adapt that pathway. So yeah, the service design, which is relatively new for us, it's a relatively new discipline, I think. It's one that will grow, and I think health information as a core element and a tool within a service design framework is a really interesting way that this whole profession will probably go, and linking into what the design councils and the various service design schools are now doing.
Thank you. So what we've heard quite a bit of is that the world is changing, the landscape's changing, and how do professionals really keep up and up to speed with that? So patients and professionals need to be on a level playing field, both equal, acting as equal partners, which leads me to a question from Monica Fletcher, Chief Executive for Education for Health.
Lovely, thank you.
Microphone, fourth row.
I just wanted to draw your attention, actually, I'm on Twitter here, and the Daily Express front page here says, "Killer heat blasts Britain." Patient information. I'm picking up your point there, Kay. Could I just bring attention to the healthcare professional educational route? And I know that you have mentioned, and actually David mentioned also, about the need to change, but where can we put some real pressure on undergraduate curriculum for both GPs, for doctors, for nurses, for other healthcare professionals? Because we've got to start changing things now, and we've got a huge number of people in the system who there is so much change to happen in the way that they truly work with patients. So some of you both seem to be really enlightened, the two GPs we've had this morning, but I'm not sure you're typical of every GP in the country. So how do we really move this forward to actually educate and help professionals to actually cope with these changes?
Who wants to kick that one off then?
I very simply, we conflate individual behaviour with we need to change the individual. Actually, we need to change the system. People, organisations, and even systems move in the direction of the questions asked of them. So if we set up questions which say, are biomedical metrics which have to be met and have incentives, for instance, laid on them, then people will not feel they have permission, or even the design of the system, to go outside of that. And I think that it's absolutely wonderful to hear what you said about giving people permission, but we need to create a system where that is business as usual. So when it comes back to what I was saying earlier on, we need to create measures which see the world through the individual's eyes. We need to capture that and feed it back, because actually something corrosive has happened over the last 20 years. First of all, David Sackett's original definition of evidence-based medicine somehow got lost in the melee. If you go back and read it, it's a very profound statement about using evidence to inform the discussion, to support the decisions the individual makes about their care with the professional. They are guidelines, not tramlines. I think, secondly, we need to help professionals to be able to reorientate to the first question I would like to ask patients in a clinic now would be, what matters most to you? Because I think that opens up the door. But I think that fundamentally, when I was at medical school, a professor of surgery said, you've got the next 40 years to learn medicine. We know from the professional activation measurement we've done, it's draft at the moment, but will be published soon, that right throughout, there's more people professionals who would embrace this now, but I think it's the system which is defeating us.
Okay, and then Andrew.
And I just want to give a sort of quick example of that, which is what the global evidence will say is, why do people not take their medication? This is asthma, so 86% of people with severe asthma do not necessarily take all their medication as prescribed. And the reasons for that are not, do I like the device, do I understand it? The reasons are, do I think this is serious? Do I think it will kill me? And am I scared of side effects? And yet those are not the two questions that are first said. And I think, again, back to patient activation, I think those are the sorts of, if you open with those questions, it just starts a very, very different dialogue. And we do know lots more about this, certainly in the last 10 years. There's much more evidence coming through, but it hasn't yet been built into practice that is still structured around medicines and reimbursements of medicines, because that is the most reliable data. Everything else is a sort of a bit of a nice to have, really.
Andrew.
I totally agree with Martin, as usual, but I think to put it another way, we've got to redefine what the core business is for the total healthcare industry, because if we just carry on trying to treat individual diseases, it's not really going to get us to where the public and patients want us to get. If we think more in terms of how can we help people to sustain their health, how can we help them to achieve the objectives they want to achieve, like getting back to work or being with their family or whatever it is, and how can we, either as healthcare professionals or in our case at PiF as social scientists, how can we support the process? And what is the general evidence, not just the healthcare evidence, what's the evidence from education, for example, about the methodologies that we should be using? Then we'll find a lot of solutions. Just to say something at a very much more nitty-gritty level, we're working with the Health Experiences Institute at Oxford and with Manchester Medical School to see if we can do some mapping work about exactly what's going on in each medical school right now with regard to patient and public involvement. So are they involving people in selection? Are they involving them in experiential learning? Are they involving them in postgrad work and so on, so that we can actually know where are we now, and also where should we be getting to, and what evidence do we actually require, both health education but also from other disciplines, to reinforce good practice. So we're going to try and do a piece of strategic work on that if we can find the resources.
Thank you. I'd like to give a final word back to Monica. With the answers to that question, did that give you the feedback or the content that you wanted, or were you thinking that you might get different answers?
I think it's just so far-ranging. I think the comments that were made there. I I'm very interested because I've seen a survey before about using patients in medical education. It's right the way through on the hierarchy. I thought what Martin said is the system mitigates. I think that's absolutely true. I do think still, though, we do need to think fundamentally. Some of us has gone on the journey, but there are many who haven't. And what do we do to take them on the journey with us? So,
Thank you very much.
Can I add a final point to that, actually? Just thinking, isn't it, if it's about education and getting into the healthcare professionals of the future, it's about making information engaging and entertaining. And when you're studying it, making health information the module that everyone wants to sign up to, that everyone wants to do. And that's about design of good education. And I think there's a role for PiF there in how you set up courses that are accredited and part of the medical system, which are the most subscribed because they're the most fun, the most enjoyable, and the most directly usable.
Well, that's a big challenge back to us. That's been a really kind of wide-ranging and I think very interesting and fruitful conversation. I would like to say a big thank you to all our panel participants. So thank you very much.